Thank you very much. I will make some remarks about the personal significance of this event today towards the end of my talk. In the meantime, I would state that time constraints will restrict me to assessing mostly the demand of immunoglobulin, but I will make some remarks about another product also towards the end. I have spoken many times on the concept of latent therapeutic demand for products, which was developed by my collaborator, Professor Jeff Stonebreaker, for factor VIII in hemophilia A some 20 years ago, and which we subsequently applied for immunoglobulin use in different scenarios. These are some of the publications in which this concept has been used to determine the LTD for factor VIII, immunoglobulin, and albumin. I draw your attention to our most recent work on estimating the LTD for IG for multiple myeloma, on which I will speak later. I will now go over the various indications for IG usage. When we model the LTD for primary immune deficiencies, PID, in the United States, we arrive at a total level which approaches closely what is actually experienced in terms of usage in high usage countries such as the USA and Australia. I draw attention, however, to the wide range of these levels for the various PIDs, reflecting the uncertainty in the data extracted to make the estimates. However, I reiterate my usual message that the combined demand for PID is projected to a higher than the total usage in many European countries. Assessing the issues around usage, we propose that there are two general schools of thought regarding IG use in PID. One view, designated the gasoline philosophy by Isabella Quinti and myself, maintains that better clinical outcomes are attained by progressively increased dosages, as shown by the orange line extracted from an industry-sponsored meta-analysis published some 15 years ago. The other view, shown by the dashed line extracted from data prospectively gathered by Isabella Quinti, shows that clinical benefits plateau at IG trough levels above 400 milligrams per liter. Therefore, clearly, there is a lot of interpatient variation, which can only be addressed through careful personalization of dosage, rather than relying on guidelines. And we need to continue to follow the data, taking nothing for granted, carefully dissecting the effects we see for each disease. In the study for Italian patients with X-linked agammaglobulinemia, it throws doubt on the benefit of regular immunoglobulin infusions in preventing chronic lung disease for this condition. The study urges strongly for personalized physiotherapy programs and prophylaxis with antibiotics for these patients. The benefits of personalized treatment and prophylaxis with antibiotics are shown by this randomized controlled trial across many Italian centers, demonstrating the benefits of antibiotic usage. I emphasize that this is not a meta-analysis, but a prospective randomized clinical trial. This is the standard which we aspire to in evidence-based medicine. The issue of IG usage across different geographies occupies us all. Italy uses roughly 1/3 as much IG as Australia across all the indications. Data for usage in the different indications is lacking, and this is a gap which must be rectified and should engage the interest of the Centro Nazionale Sangue. In this study, mortality in PID patients in Italy is estimated as about 1.7% each year. In Australia, depending on the status of the patient, that is, presence or absence of complications, including immune dysregulation, bronchostasis, etc., a mortality of about 0.8% is estimated. Hence, it seems that by using three times as much IG overall, Australia is achieving a mortality in these patients which is roughly half that in Italy. It must be noted, however, that mortality is very low in both countries, reflecting the high level of care accorded to these patients. It can be argued that mortality is a relatively insensitive indicator of the overall condition of PID patients. Comparing the UK and Australia, again with a threefold difference in IG usage, these studies suggest that Australian patients have lower levels of bronchostasis. This is possibly more a reflection of diagnostic delay than of IG usage levels, and again, more studies prospectively monitoring patients are very desirable. A similar situation ensues when comparing Australia and New Zealand, where comparisons are more valid given the similarity in the health systems in the two countries, including their plasma fractionation arrangements. Again, New Zealand patients show an apparent level of bronchostasis which is twice that found in Australian patients. Overall, Australia's usage of IG, which is amongst the highest in the world, is delivering a bang for the buck, but I continue to advocate for more clinical studies designed to eliminate geographical and other sources of bias. Another important area is the perception of the patients regarding their quality of life. In this survey from IPOPE in 2014, it is intriguing that the level of IG provision has no effect on patient health-related quality of life. Note the situation in Latin America, where patient access to product is relatively low, and compare it to Canada, in this period the highest IG user. I also point out the similarity between the two routes of administration, IVIG and SCIG. Other industry-generated measures, such as the concentration of IG in IVIG formulations, also have no effect on patient perception of health-related quality of life, as shown in the study with my collaborator, Isabella Quinti, again, from some years ago. Similar studies were found when assessing the effect of different infusion speeds of the product. I would point out that many of the changes which we have seen with IG provision in the past 20 years are the result of industry-generated modifications for commercial reasons or as a result of the particular healthcare environment in the United States, the most important market for the industry. Whenever these changes are seen as deleterious to the delivery of IG in Europe, because, for example, of effects on product yield, this should be kept in mind, and procurement conditions should reflect actual European practice and needs. It is frequently proposed that there are no alternatives to plasma-derived immunoglobulin for the treatment of PID, and that there will never be any. An interesting body of work generated by Gigagen, a company which is a subsidiary of Grifols, indicates that this may not be the case. The company's scientists have developed recombinant immunoglobulin molecules against the main organisms which are involved in respiratory tract infections in PID patients. These include antibodies against pneumococcus and Haemophilus. This data for pneumococcus recombinant IG shows that it shows higher potency against pneumococcus, whether on its own or in a cocktail with polyclonal IVIG, than AVIG on its own. The authors are restrained, commendably so, in their conclusions, but point out that the promise of this library of recombinant antibodies in supplementing or substituting the polyclonal IG supply. I find it encouraging that this development is being pursued by a traditional plasma fractionator. I now turn to the next group of indications, the autoimmune neuropathies, which in many countries form the largest users of IG. Again, LTD modeling indicates levels of demand which are higher than the total IG usage in many countries, and the variation due to data uncertainty is also observed. Alternatives to IG for the treatment of these diseases already exist in the form of plasma exchange as well as steroids, as has been repeatedly concluded by the Cochrane collaboration. CIDP is the highest user of IG in this group of indications, as is shown by this data from the Australian National Blood Authority on the left part of the slide. On the right-hand part, it is interesting that in the pivotal clinical trial establishing IG's efficacy for CIDP, the trial design required every randomized subject to be taken off IVIG, proven to deteriorate, and then restabilized with IVIG. Yet, 37% of subjects who were then randomized to placebo remained stable for the 24-week study period. This is a strong indication of a true placebo effect. This was also observed in other studies of IG use in CIDP, where a significant placebo effect was observed when relapse was the outcome measure, but a much smaller effect when actual improvement was the measure. I propose that this level of analysis needs to be factored in by regulators when they approve IG products for CIDP, and that the scrutiny of the products needs to be continued over the whole of the product's life cycle. There are many excellent reviews on our current understanding of the pathophysiological mechanisms in primary autoimmune neuropathies, which lead to the strategic therapeutic aspects that target these mechanisms. I am going to focus on the blockage of the Fc neonatal receptor, FcRn, as the mechanism to prevent recycled immunoglobulin in the lysosomes from re-entering the blood, leading to a drop in circulating Ig levels, including the levels of the pathological autoantibodies involved in these diseases. Currently, the most important of these FcRn blockers is efgartigimod, commercialized as Vyvgart by argenx, a company based in this brave and beautiful country of Belgium, where we are today. This is a synthetic antibody fragment which binds the FcRn. It has been validated for the treatment of myasthenia gravis, MG, in patients which are positive for antibodies to the acetylcholine receptor, and approved for this indication by the main regulatory agencies. In this retrospective study, comparing it to IVIG, it was found to have a superior therapeutic effect. And this is another retrospective study showing a similar superior effect. A randomized controlled comparison between the two modalities is desirable to confirm this proposed superiority of efgartigimod to IVIG. Again, a retrospective study from the same group as in the previous slide, claiming superiority of the efgartigimod to IVIG in the treatment of Guillain-Barré syndrome, GBS. However, myasthenia gravis is a relatively small user of IG, and companies seeking validation of alternatives are progressing to other indications after they show efficacy for MG. argenx has acquired this approval based on the ADHERE trial, a randomized controls trial designed as shown on the slide. I draw attention to the particular feature of this trial in which CID patients were, so to speak, weaned onto the product, and non-responders were excluded before randomization. I assume that this particular and peculiar feature of the trial was negotiated with the regulatory authorities. The trial showed efficacy for efgartigimod, formulated to include hyaluronidase to facilitate subcutaneous access. Based on the ADHERE trial, the product was approved for treating CIDP in the USA and in Europe. The design of the ADHERE trial, however, elicited this editorial after efgartigimod had been approved, whereby it was pointed out that the design meant that a proportion of patients first treated with the drug would not experience any improvement. The editorial encouraged rigorous clinical monitoring when the drug entered real-world practice. Patient expectations needed to be managed, and further criteria to define a dose and determine discontinuation of the drug were required. These cautionary statements were validated with this report, showing that 4 of 9 stable CIDP patients transitioned from IVIG to efgartigimod had severe disease relapse and needed rescue therapy with IVIG, which only succeeded in 1 patient and failed with the other 3, who had to be treated ineffectively with other modalities. It should be noted that the other 5 patients in this series neither deteriorated, but neither did they improve. The authors and an accompanying editorial expressed great caution regarding the use of efgartigimod in CIDP and recommended the identification of patient subsets which may be responsive before further use of this drug in CIDP. I therefore maintain that the use of efgartigimod in CIDP is not yet validated and that this series of events illustrates the need for regulators to demand real-world data in the post-approval of this drug or indeed any drug with rapid action in the event of adverse events. A few other alternative therapies in the anti-FcRn group. This monoclonal antibody to the FcRn is approved by the EMA and the FDA for treating MG, but appears ineffective in CIDP. Again, nipocalimab from J&J is approved for MG and is being trialed for CIDP, but don't hold your breath. Immunovant has announced positive results for batoclimab, both MG and CIDP indications, but the company is not pursuing them. A clinical trial for CIDP, in fact, has been suspended. And this is curious, as in a network meta-analysis ranking therapies for MG, batoclimab ranked first in some parameters. To sum up on FcRn antagonists, the low-hanging fruit of myasthenia gravis appears well validated, but the real-world evidence for GBS and above all CIDP is deficient. And in the case of CIDP, great caution is required in transitioning patients which are stable to IVIG, which are stable on IVIG to efgartigimod, given the risk of irreversible relapse. I now turn to the secondary immune deficiencies leading to hypogammaglobulinemia, which collectively now constitute the largest group of indications approved for IG treatment in Australia, currently among the highest country user globally. We know that this group is also driving strongly IG demand in Europe. I have the pleasure of leading a group of investigators in Australia and Europe in assessing the demand of IG for this group. We started our work by constructing an LTD model for IG use in multiple myeloma in Australia, initially for no other reason than that the data to populate such a model seemed readily available. As always, we started by constructing an influence diagram, trying to capture the therapeutic pathway whereby IG is used to treat hypogammaglobulinemia in multiple myeloma. We used this initially to calculate a base case for IG LTD, simply using the values extracted from the literature to do the estimate without any statistical modeling. We noted that the literature proposed 2 estimates of prevalence for multiple myeloma, with 30-year prevalence more approximating the current epidemiology of the disease, in which survival is improving because of the new treatments. We compared these estimates for the base case and noted that the base case calculated using the 30-year prevalence was slightly closer to the actual usage recorded in Australia. Given the uncertainties in the parameters, we then modeled them using statistical distributions. These estimates extracted from the distributions confirmed that the 30-year prevalence was very close to the observed usage. We therefore consider that this model has a good predictive capacity. This tornado diagram extracted from the sensitivity analysis generated by the model shows the great effect of dosage on the eventual LTT. Other important parameters include the prevalence of multiple myeloma and the probability and the duration of treatment. So far, we have presented these results to the ISBT Congress in Perth and to the ECID Congress in Vienna late last year, and we have just been successful in getting a grant from the Australian National Blood Authority to continue this work by studying the other areas of secondary immune deficiency, with the aim of providing policymakers in the public health sector with tools to assist in assessing and projecting IG demand. In this work, we have assessed the evidence for the use of IG in multiple myeloma in Australia. This paper suggests that several aspects of this evidence base is poor. In particular, the use of IG was not associated with increased survival, irrespective of the level of baseline hypogammaglobulinemia, and did not affect infection-related mortality. The rapidly improving life expectancy in multiple myeloma, brought on by the continuous improvements in treatments, which I shall glance at in the next slide, and the treatment protocols which have been optimized, contributes to the different outcomes with longer prevalence. This is shown in this slide. It is important to note that all these treatment protocols are now including prophylaxis with IG for the treatment course. This area of IG use is very detached from the rest of the IG usage landscape and is being carried out in an area of practice which lacks the awareness of the position of IG in the blood safety paradigm. And we may expect this expansion in IG use to continue at an accelerated pace with the rapidly emerging novel therapies, including the range of available biphasic monoclonal antibodies as well as the CAR T-cell therapies. All these treatments augment and induce the state of immunosuppression experienced by these patients from their primary disease, and current protocols require the continued prophylaxis with IG. I was struck by the way in which IG is incorporated in the protocols for clinical trials for biphasic antibodies, with IG included in the list of supporting medicines along with steroids and paracetamol, with little inclusion of personalized use and no criteria for the duration of treatment with IG. And if I may share a personal experience at a meeting I attended in Melbourne some months ago, when I asked the speaker of a presentation on the use of supportive medicines in myeloma why he had not mentioned IG, he somewhat sheepishly replied that it was because it was supplied free and did not impact on the budget for pharmaceutical support for multiple myeloma. I suggest that this opens up an area for policy reform and that the incorporation of IG into the overall costs of therapy is desirable for management and transparency. As with primary immune deficiency, a clear role emerges for prophylaxis with antibiotics, which was validated with this randomized trial carried out in the Australia Pacific region some 3 years ago, showing equivalent survival of patients treated with antibiotics compared with IG. This preliminary trial is now being followed up with recruitment for another, larger phase 3 study, and I am informed reliably that recruitment for this study is experiencing difficulty as there is reluctance on the part of potential trial subjects to be randomized to the antibiotic arm following their stabilization with IG. And this is a problem which needs to be confronted as demand for IG in this area continues to rise. I have little time to address the demand for other products, but I wish to make some points regarding albumin. Albumin is frequently ignored in the conversation around supply-demand issues as it is a product of IG manufacture and is absorbed by the market as a commodity. Few concerns are raised about albumin shortages, and its usage is therefore relatively unscrutinized. I would maintain that if demand is to be based on evidence of benefit, then this has to be demonstrated for all products, irrespective of supply issues. Albumin is treated more or less as a generic product, with minimal evidence for efficacy being requested by the regulators, which is regrettable. In recent years, as albumin's traditional role in fluid resuscitation has been overtaken by new therapeutic approaches, A number of new indications drawing on the pharmaceutical properties associated with the albumin molecule's higher order structure have emerged. These have included sepsis and septic shock. Many clinical trials have returned results indicating no benefit on survival, despite much randomized, much promising preclinical data and some subgroup analyses in earlier trials, like the Australian SAFE study from 20 years ago. The most recent studies, two of which are shown on the slide, continue to show equivocal results. Therefore, in the case of sepsis, we are still in a situation of equipoise, and the effort to market albumin as some kind of general panacea should be resisted by the regulatory authorities. Clinical trials are still needed, but I do not sense any appetite for them from the industry. The other area where albumin-specific and non-oncotic effect have yielded promising therapeutic results have been in hepatology, where early findings using albumin as a volume replacer following paracentesis have been augmented with findings in other groups of patients, including spontaneous bacterial peritonitis and the hepatorenal syndrome. These findings have culminated in the large-scale trial known as the ANSWER study published in The Lancet, in which long-term albumin administration in patients with decompensated cirrhosis had a benefit on survival. This trial created great interest in albumin enthusiasts, including myself, but subsequent trials have also thrown doubt on the universality of these findings. We therefore continue to find ourselves at equipoise also for this indication. I propose that the heterogeneity in the clinical results obtained with albumin for similar patient populations and for the same indication are at least partially due to the heterogeneity in albumin products from different manufacturers. The long-standing assumption that the albumin molecule is a passive colloidal suspension resistant to the conditions of plasma fractionation is incorrect, and the higher order effects of albumin are due to molecular moieties which are vulnerable to these conditions. This is shown by several studies, including this one by my collaborator Filippo Moro of Kedrion. Properties such as antioxidant capacity, drug binding and transport, anti-inflammatory activity, etc., many of which are mediating conditions such as sepsis and cirrhosis, are particularly affected by these variations. As long as the industry and the regulators are content to wallow in the complacency of viewing albumin as a passive colloid rather than as a complex and easily damaged molecule, the state of affairs will continue. As I approach the end of my talk, I continue to appeal for a recognition that the problems which we face in plasma product demand are many, that they are complex, that they demand a multifaceted approach synthesizing clinical factors, public policy, plasma management, and there are therefore no easy solutions. I hope that I have conveyed adequately my conviction that we need to source, follow, and interpret as best we can the data available from the multitude of disciplines making up our field. I know that data is hard to find, but my experience is that much is available, and where it is not, work projects can be constructed to sources. Ignore the easy solutions proposed by the lazy proponents who proclaim legends such as off-label use. If anything, the problem is more on-label use, but the labels are questionable. I appeal in an era where it is constantly under attack for the defense and practice of evidence-based medicine, and I hope that I have conveyed adequately the importance of monitoring real-world evidence to arrive at some understanding of the real effectiveness of our therapies. And no, none of this is easy, but as George Bernard Shaw once wrote, life is not meant to be easy, but it can be delightful. I feel very privileged here in this fine historic city in Belgium, a country which is the epitome of European culture and civilization, unfortunately geographically placed in the cockpit of European wars. And so I dedicate this talk to the 248 citizens of Leuven, who on the 25th of August 1914 were murdered by the soldiers of a neighboring and more powerful nation, led by an autocratic megalomaniac, which twice in the last century invaded Belgium in breach of the most solemn international treaties. They sacked the town and burned down the centuries-old historical library, destroying many irreplaceable medieval books and manuscripts. And as I ended my talk 2 years ago at this meeting in Leuven with the words of John Fitzgerald Kennedy, so I close today by paraphrasing him once more. And I say to those who think that fascism is indeed regrettable, but that they must take care for their NIH grants and their FDA licenses and their visas for conferences in the USA, to those I say, let them come to Leuven.